So with that, I would like to introduce our panelists. We have, a lot of them will be very familiar to you from this morning. We have Dr. Arpine Barsegian, Dr. Andrew Iwach, Dr. Sandra Harpster, Nick Marsh-Armstrong again, and Dr. Terri Pickering. And as well, we have a newcomer, Tara LeBlanc, glaucoma patient. So this is our first Q&A session of the day. Please, again, use those cards on your table to either write out your question, or you could scan the QR code on the back. We have lots of questions in already, so we will do our best, I promise. We'll do our best to try to get to as many of them as possible. So with that, I would actually like to start with Tara LeBlanc. Please briefly share your experience with glaucoma treatments and your journey. You know, what medications do you take, what procedures have you undergone, et cetera.
Hi, can everyone hear me? Is it on? Okay. I really can't see. There's bright lights, and I had to take my glasses off, so there's that. Hi, I'm Tara LeBlanc. I am from South Louisiana. I was diagnosed with glaucoma probably 15, 16 years ago. More than likely had it 3 or 4 years before that, but the doctors just overlooked the high pressure. I was in right at 40. Since then, I've had 16 surgeries on my right eye, 9 on my left eye. I've had a stent that lasted about 3 weeks, and scar tissue won't go away. I've had a trap. I currently take 4 eye drops right now, some twice a day, some once a day. I was up to 8 about 3 months ago, but we're trying to taper it down. I've had cataracts as well on my right eye, which did not go so well with me as being a glaucoma patient. I've received a lot of bleeding and swelling behind the eye caused from that. So it's been a definite journey, I can say. I was teasing someone. I have glasses on, and this is my glasses of the hour at 11:30 on a Saturday, because I have about 5 pair that you just pick one, whichever one works at that time. Here it is. I think that's it.
Great, thank you. So I think our first question I'd like to direct to Dr. Harpster, because you mentioned in your lecture that you should maybe press your tear duct, and so the question came in, is it the side of your nose, or is it your tear duct? Like, where exactly are you targeting with that pinching?
That's an excellent question. So it's not so much the side of the nose, it's more closer to the tear duct. And the reason for that is that's the way tears or glaucoma medication drains through these canals into the nose. And so as long as you're not pressing, low down on your nose and you're really getting into that triangle shape that your eye makes, it can help decrease the amount of tears that go into the nasal passage.
Yeah, please, Dr. Iwach.
Hello, check. Okay, good. There's another way to do it. And a number of years ago, I was talking to one of my colleagues who's an oculoplastic surgeon. What they do is they work on the eyelids. And by the way, the reason this is all of an issue, hopefully you don't cry often, but when you do cry, you'll notice that your nose runs. There's a small duct that goes to your nose. And I was asking him, what's the mechanism? And he said, well, really what does it is blinking. And so what we talked about, he said, well, if you really want to keep something in the eye, the other way to do it is not to blink. So with my patients, I'll tell them, you pop your drop in, and then if you keep your eyes closed, but then for how long? So there was a study done in the late 70s that showed that within 5 minutes, most of the drug is absorbed. So after 2 to 3 minutes, most of the drug is done. Well, how do you know it's 2 to 3 minutes if your eye is closed? Well, listen to the radio or set a timer. But the challenge is with the punctal occlusion, which my colleagues, we all talk about it, but it's actually technically difficult to do. And so at night it's easy because you go to sleep. And so it takes away the whole issue of bringing your hands near your eyes, and it's an alternative. Neither is perfect, but as far as simplicity, and it's on our GRF website as an alternative to the more commonly talked about punctal occlusion.
Actually, keep that microphone on, Dr. Iwach, because we do have a question that someone in the room says that their doctor recommends they do a lot of blinking after taking their latanoprost drops. So am I hearing the exact opposite?
Well, first of all, thank you for asking that question.
Your check is in the mail.
Depends what your objective is. On eye drops, how much do you need? Any part of one drop is enough. Am I going to overdose with two? No, you're not, because it's going to wash out the others. If you're on more than one medication, ideally wait at least 5 minutes, because theoretically one could wash out the other. So those are some high-level things. If your goal is to maximize the absorption in the eye and minimize systemic absorption, you're going to do either punctal occlusion or keep your eyes closed. It keeps the drug there, it gets absorbed. And these are helpful tips. If you don't keep your eyes closed, if you don't do punctal occlusion, it's not the end of the world. But technically, from a pharmacologic point of view, if you want to maximize how much effect you get from the drug and minimize the systemic absorption, for example, with beta blockers, these are eye drops that we use, I think very commonly still in some areas, that can affect your lungs. I mean, so if you have asthma or emphysema, that's just one of the important things. We need to know your medical history, because you don't want to treat one drug with another. If you come in here and all of a sudden you have asthma or emphysema, and we see that you're on a beta blocker, we're going to say, wait, maybe we don't need you on that. Beta blockers can also take away some of your energy. So in fact, the people who notice that are not you, your family. So oftentimes when a patient comes in with a family member, I'll ask the patient, how are you doing? I'll turn to their family and say, do you agree? And they'll say, oh no, we're seeing these other problems.
Thank you. So this question is for any of you. Can you please talk about the preservatives in eye drops and cornea damage and whether that damage could be severe or permanent? Who wants to start?
Can everybody hear me? Okay.
Yes, good.
Yeah. I can chime in on that. So classically, glaucoma drops have a preservative in it, which is called BAK or benzalkonium chloride. And the goal of the preservative is to help increase the penetration of the medication into the eye, but also to preserve the drop for as long as possible. Unfortunately, preservatives do add up in the eye, and they can lead to allergies and side effects. Sometimes when our patients come in with red eyes after using glaucoma drops, we're kind of asking ourselves, is it the medication or is it the preservative in the medication that's causing the red eye? Sometimes we don't know, and it's a matter of just trial and error. We either switch you to a preservative-free drop, we see how you do, usually most of the time, preservative-free drops are tolerated a bit better, especially long-term, since this is a lifelong disease. Unfortunately, preservative-free drops tend to be more expensive, and we have to play this game with insurance companies where you have to be on a drop with preservatives first and not tolerate it, and then we can theoretically try to apply for certain authorizations, which are the bane of our existence, and to try to get you the preservative-free drops. There's an important caveat with Alphagan or brimonidine, which Dr. Harpster very beautifully presented, that kind of, in our experience, I think has the highest rate of intolerance, redness, side effects. And we always play that game where we say, is it the BAK or the benzalkonium chloride, or is it the medication? Sometimes as a trial, I'll switch my patients to a different type of Alphagan, which has another preservative in it. It's called Purite, and this is called Alphagan P, like Peter, which is supposed to be much better tolerated than BAK. Unfortunately, we don't have a preservative-free form of this medication, but that's an option for patients who are experiencing brimonidine allergies.
Great, thank you. Anyone else want to weigh in?
I was just going to say that's another reason to consider laser. And so laser doesning always work. Even when it does work, it doesn't last forever. On average, 2 to 3 years, you'll have some effect. But as was pointed out by Dr. Barsegian, is that, and my colleague Dr. Pickering, is the newer generation lasers can be repeated. And so whereas earlier on when the first technology came out, you really had one, so to speak, shot at it. But now we can actually, if it worked, and we can go back and buy some time. So SLT plays an important role in helping patients.
Great, thank you. So you just mentioned that SLT can be repeated, Dr. Iwach. Now, what about drops after SLT? Do some patients still need their drops? Tara's saying yes. Your microphones are on. I don't think you have to mess with them. I think you could just go for it.
Yeah, I think I actually had 6 SLTs in both eyes over time. And yes, I'm still on eye drops. I think the physicians were just trying to just throw something else at me, trying to make sure. I am blessed because my left eye vision has not been impacted nearly as much. My right eye, actually with glasses, I still, on a good day, I can still get like 20/30. So I think they're just really trying to be invasive in the whole process for me. But yes, I'm still on, after all of the surgeries, I'm still on eye drops.
Yeah, Tara, while you have the microphone, someone wants to know, how do you prepare yourself for all these procedures?
Well, I was really glad whoever said this morning that alcohol was not but no, I shouldn't say that. I shouldn't. Mentally, I think Bianca said it great this morning. There's 3 aspects of it: emotionally, physically, and medically. And for me, mentally, I do hit a lot of lows. I have a very supportive family that really helps me. I have 2 adult girl children and my husband. So I think that is really what supports me, because when I get down in the dumps, knowing what's coming next, I really get the emotional support from the family. I'll just go ahead and say I'm already nervous when I get back not next week, but the week after. I have to take another visual field and all type of testing to see what the next step is on my right eye. So I'm already anxious about that.
We have a question for Dr. Marsh-Armstrong, which is, what hope can you provide for potential scientific breakthroughs within the next few years to help glaucoma patients? It should be
live.
on. Yeah.
Yeah. So I'm very excited. I tend to be a glass half empty kind of person, and yet I'm excited and optimistic for the near future. I think that we're really in a scientific revolution right now. There have been so many advances on so many diseases. I think cancer is probably the best example, where there are these targeted treatments that are just absolutely amazing. They're nothing that could have been in the imagination a decade ago are now the reality. And I think that that's something that is coming to neurodegenerative diseases. We've seen some amazing breakthroughs and in terms of what's becoming available for the treatment of Alzheimer's, for example. Some of us believe that glaucoma is very similar to many other neurodegenerative diseases, and I think that some of the same types of advances are coming soon to glaucoma. And I think we all recognize that AI is transforming everything. And I think that even though some of us are, used to read a lot of sci-fi as a young kid, so we're somewhat nervous about some of the negative consequences of AI that may come, but the potential for good, particularly for medicine, it is amazing. It is, what can come in the next few years may surprise us all. And so being a glass half empty kind of person, I still am incredibly optimistic for treatments for glaucoma in the near future.
Wonderful. And I have to say, from my perspective, what gives me hope is reading all of the applications for Schaefer grants from some really optimistic and just amazing. Some of them are young, some of them are very established professors, but if they have a new idea, they can come to us and we can give them some pilot funding to see, to make that dream a reality. So we have a lot of hope here at GRF for the future of research and glaucoma treatments. Dr. Pickering, do you want to talk about dry eye? We know that glaucoma drops do cause dry eye. What are some best ways to manage dry eye as a result of your drops?
Dry eye is very common, and it really depends on the number of medications that you use. So for my patients who have dry eye, I try to use combination drops if they do need to be on more than one medication. We're fortunate now is that we have 2 combination drops that I can think of that are available commercially that are also preservative-free. So as the years pass, the treatment options are expanding. For patients who need more intensive therapy, there are compounding pharmacies. Unfortunately, you may have to pay out of pocket for that, but the options are expanding for patients with dry eye. I also will work with a dry eye specialist, someone who's a corneal and external disease specialist. Locally, I'll find someone and we'll work together to optimize treatment for patients.
Tara, is that something you experience?
Yes, I'm struggling here, mainly change in climate, no humidity, drier air, which really affects my eyes. This morning I woke up and they were bloodshot, like I had been out all night doing something. I was not, but as I put my drops in, and I am trying Vivi, is that what, a dry eye, which seems to be helping a little bit throughout the day. It does. So, and for me, dry eye impacts my vision. It definitely lowers my vision. Very foggy, cloudy, and that's when I know, like, okay, yeah, it's really bad. Let's add some more lubricant drops in.
You live in Louisiana, I live in Florida, so there are occasionally downsides to living at sea level. Any change in climate can be very dramatic for us.
Can I just add one thing about the?
Of course.
So we often recommend lubricating eye drops for patients with dry eyes that have glaucoma, and I think if you're already taking several glaucoma drops, to try and get the preservative-free lubricating drops.
Yeah.
And the other thing is, it's the symptoms you'll have are dependent on where you are, but also what you're doing. So if you're doing reading and computer work, when you're looking intensely, you override your natural blink rate, so you're more likely to have symptoms. So just be aware of that. Maybe before you have symptoms, go ahead and put in an eye drop. So let's say typically the dry eye symptoms are worse later in the day. So let's say every 2 or 3 o'clock in the afternoon, you're having symptoms. You may consider actually going ahead and using them earlier in the day, kind of coating it to maybe give yourself more time. Also be aware of your surroundings. Anything that dries your face dries your eye. So if there's a fan blowing at you where your desk is or where you're working, just be aware of that. When you go outside, if it's windy, make sure anything you can do to kind of just reduce that dryness will give you more ability to continue doing what you like to do.
My husband complains a little bit because I have the dry eye, like little refresh preservative free everywhere in the house, in my office where I work from, in the bedroom, on the couch. They're everywhere in our vehicles. They're in my pockets at all times. So yeah, dry eye is really impactful. If you haven't really researched it and discussed it with your physician, please do, because it does relieve a lot of your issues if you can really get your eyes not to be as dry.
And also, very importantly, tell your eye doctor about it. Because we may look at your eye and at that moment, yeah, cornea looks pretty good, you looks all right. But if share with them, but every afternoon my vision is blurred, my eyes get irritated, it feels like something's in my eyes. So that'll then trigger us to take a look at that specific issue and explore. Maybe we have a different medication, regimen, laser, and so forth.
Sorry, if I could just add one more thing, if that's okay.
No, of course.
So when my patients tell me, the drops are drying my eyes out, which they likely are, there's 2 other options I suggest sometimes. One is actually, I call it to sandwich the glaucoma drop with a preservative-free artificial tears 5 minutes before and 5 minutes after. I found that does prevent the onset of some dry eye symptoms later on. The other great treatment for dry eye, which also helps your glaucoma in a roundabout way, is we keep talking about punctal occlusion because tears are created up here, they flow into the eye, and then they flow into the nose through an opening on the bottom eyelid through which 90% of the tears flow, and an opening on the upper eyelid through which 10% of the tears flow. There's actually something called punctal plugs, which are literally little drains we place, rather not drains, but plugs, quite literally, that block the tear duct to allow the tears to stay on your eyes for longer. And not only is that a great option for dryness, but it actually allows the glaucoma drops to stay on your eyes for longer as well. So I place plugs routinely all the time for my glaucoma patients with dry eye.
Nick, everyone else has weighed in. Any thoughts on dry eye? Okay, whoever's asked that question, clearly you hit on a hot button topic, so thank you for that question. Actually, so for Dr. Harpster, the question is, can a bottle of therapy drops be used until the bottle is empty, or are they only supposed to be used for a certain number of days?
That's a great question, and it depends on the medication. And if it's being refrigerated. So, for example, with latanoprost, we recommend, or prostaglandins, that they're stored in the refrigerator. But then once they've been opened, they can be stored outside of the refrigerator for 30 days, or maybe up to 6 weeks. And then at that point, I would recommend throwing them away. So if a drop has been open for a long period of time, I would throw it away, even if it's not expired.
Great. So for the surgeons at the panel, what are your special protocols for open-angle glaucoma patients having cataract surgery? Who wants to start?
So generally, I like to stage it depending on the type of glaucoma we know is open angle, and then kind of how advanced their patient's glaucoma is. I do try to combine the procedure with what I mentioned as a mixed procedure, and there are a variety of them on the market. Generally speaking, I spoke about 3 mixed procedures. 2 of them were stents that are placed in the angle of the eye to increase fluid outflow. I'll typically, if somebody has kind of milder to moderate glaucoma, I'll typically recommend one of those 2 stents during cataract surgery. The third procedure I mentioned, the Omni, doesn't have a stent, but it consists of 2 different procedures, one of which injects a little jelly to inflate the drainage system, and the other one which actually makes an incision into the drainage system to increase fluid outflow. I'll find that with that procedure, I get a little bit more of a dramatic pressure reduction in the eye. And so if somebody has moderate to severe glaucoma and I'm performing cataract surgery, I'll typically combine it with an Omni. The main caveat with the Omni is that there's more bleeding in the eye after surgery than there is with the 2 stents. So the day after surgery, your vision will be much blurrier than what we would expect if you had just had cataract surgery alone. We do warn our patients about this in advance, and we know that over time, a few weeks, some TLC, steroid eye drops, which we give you after surgery, the blood will resolve and the vision will end up where it was supposed to have ended up after cataract surgery.
Yeah, I'll echo what you said. I think it's really important to have your expectations at the right level. That if you talk to your friends and they don't have glaucoma and they had cataract surgery and say, oh my goodness, the next day I was fine, this and that. And so just be aware that you may have a little bit of bleeding. And unfortunately, for all the different procedures, it's funny, certain things in surgery we all do, because it's pretty consistent, capsulorhexis. But there are other things where you see a lot of variation, which means that depending on the surgeon, what works in their hands, the good news is we have lots of different options. From your side, one of the things we do want to make sure is we want to reduce the risk of bleeding. So if you're on aspirin or warfarin or something, sometimes we have to leave you on it, but we do want to talk to your internist or your cardiologist to see maybe we can get you off of that for a few weeks to reduce the risk of that. Number 2 is after surgery, even with these minimally invasive, our incisions are self-sealing, we just don't want you to do a lot of heavy activity. Not a good day to go move furniture, okay? So you want to kind of be prepared mentally that, for that first few days, first week at least, that you're going to have a lighter schedule. You're not going to do a lot of computer work and so forth. And then what we'll do is when we see you, we'll give you feedback and say, you know what, I see a little bit of blood here. I really want you to kind of take it easy. And you'll notice if you do have blood, in the morning your vision's better because the blood will settle down. If you go down to Fisherman's Wharf, it's like those little souvenirs where you shake up the snowflakes. Then you start around the day, it's cloudier. So it'd be from our side, listen carefully to your surgeon's advice, follow it, and then that'll make the post-operative course smoother for you.
Question for Nick. Is the research of glaucoma in the U.S. on par with the rest of the world, like in Europe or in Asia, or are we light years ahead of everybody else? Where do we stand?
Can you hear? Yes. So it's a complicated question, and I think that different people have different opinions. I think that everyone would agree that up to this point, the U.S. has been at the forefront of all biomedical research. I think everybody would also agree that, and I sit as an editorial board member of a prestigious eye journal, that the number of submissions and important science that's coming from other places, particularly China, are skyrocketing relative to the U.S. So the U.S. is beginning to lose some of its preeminence in science. And that is, it's horrifying to see, in all honesty. So I think that the U.S. can has been and should continue to be the preeminent leader in science. And I think that we scientists should do more to advocate for ourselves and to make sure that we remain the preeminent force, and not just for us Americans, but also for the world, that we remain as the preeminent driver of scientific innovation.
Great answer. Yeah. So this is a question for any of you. We all know that glaucoma is considered a neurodegenerative disease, and in fact, it was CFC1 that I think came up with that real definition of glaucoma as a neurodegenerative disease. So the question is there any research or are there any thoughts about glaucoma and its association with other neurodegenerative diseases or cognitive dysfunction?
That of course, is a topic that's near and dear to my heart, because I firmly believe that glaucoma is a neurodegenerative disease. It occurs in aged populations. There are lots of exceptions, but there are many commonalities and many of the same risk factors for all these neurodegenerative diseases. But more importantly, we think that there are shared mechanisms, meaning that the reason why the cells become sick and eventually die are very common in many neurodegenerative diseases. It also should be said that the eye has manifestations for other diseases. So there's a lot of research going on in Alzheimer's now, specifically that is looking at the eye. Why? Because you can actually look into the eye. And so there's good Alzheimer's research that is occurring in the eye. But the flip side is also true, namely that we're learning a huge amount about glaucoma from what's emerging in other neurodegenerative research. So I think that the commonalities are many and will continue to expand.
There are two things I would like to add to that. One is some of you may have heard of the term oculomics, which is an initiative that's been coming out of the NIH, where they're actually looking for signs of systemic disease in the eye. And as Dr. Marsh-Armstrong said, there is very real evidence that certain systemic manifestations actually do appear in the eye first. The second thing that I want to mention is that our fourth Catalyst for a Cure initiative actually is looking for parallels between glaucoma and other neurodegenerative diseases, including Alzheimer's, and we even have a brain tumor researcher looking for some commonalities between the two. So from a research perspective, not from like a pathology perspective or anything like that, I should mention that. So let's talk a little bit about inflammation with regards to nerve damage. Dr. Iwach, you mentioned GLP-1 drugs earlier from a very different side of things, and congratulations on adding years to your life, by the way. But this person would like to know, are there any, is there any association, a positive association between GLP-1 and glaucoma?
So I'm smiling because this was actually, I got introduced to the GLP-1 agonist 3.5 years ago by one of my patients. She was very nice, dermatologist. She actually allowed me to share her name, but I won't. And she just told me in passing that she'd lost 10 pounds. And I got to ask, how'd you do that? And so she said some drug, and I'd never heard of it. And so she was old school, so she didn't email me, she didn't fax me. She actually mailed me 2 paper articles. And I read them, and I go, oh my goodness, this is really pretty amazing. And so there are side effects, there are access, there's cost, and so forth. But what I did learn is I hadn't really studied, and my issues were, by the way, they were about to start treating me for diabetes. And all my blood work, I just had it this week again. I'm actually going to talk on this. I decided when I'm going to do this, it's the best decision, the worst decision of my life. So I started collecting data on myself, doing full body MRI so I can see where the fat went and so forth. But it helped me tremendously for me personally. But in the process, I started reading more about obesity. And what I did not realize was the link between obesity and inflammation. And actually, I was going to ask Nicholas about this later, but I'm going to ask you now, it seems that the GLP-1s, it's all new, but that their role potentially, and the role of obesity in inflammation, how do you see that playing out?
So it's an emerging area, and there's a lot of people looking at it in many different aspects. So I recently was at a conference in Texas where someone was talking about the connection between inflammation and arthritis. In that particular context, the question is, the hypothesis, because at this point it really is just a hypothesis, that it's all this extra inflammation is due to the accumulation of all this basically bad stuff, all this oxidative lipids and other toxins that would be cleared. So, if in the conditions where obesity, you have essentially the storage of all this extra bad stuff that can trigger your inflammatory system, and then your inflammatory system, what it does to your joints or what it does to your nerve can be deleterious. So that's my best understanding right now, that the link between obesity and a number of diseases is all really mediated by inflammation, the inflammation that is caused by the obesity.
I would put a word of caution. These are serious drugs.
Yes.
And so that you don't do this at home by yourself. I know on the internet you can get all types of stuff, and it's a team approach. So if you do, but I went to a dietitian, I go to the gym, I see my internet, you follow me? So this is, but if carefully monitored, and again, not everyone can tolerate it and so forth, but it's really a new tool, and it's really impacting globally. I was reading an article about the airlines, so that they think that so many people are on this that they're going to use less fuel for some of their flights. There is data from Walmart that if you look at people who buy their food there and the GLP-1s, that they're buying 30% less food. It's an amazing drug. Personally, it changes how you look at things. My whole life I've been struggling not to eat too much, right? With this, I still love eating, but I don't have to eat. It's amazing that this little shot, 1 milliliter in my leg, will affect my thinking and my brain for 7 to 10 days. And as the drug wears off, all of a sudden I get that noise, that food noise again. It's just fascinating. Anyway,
Yes.
As a research subject, I find it interesting.
Fascinating is a great answer. So speaking of members of the healthcare team and having glaucoma be like a group effort, a question for you, Tara, is why do you think it's important to share your diagnosis of glaucoma and your treatment regimen with everyone else involved in your care?
Well, if you're unhealthy like I am, I take way too much prescribed medications. But I have a lot of other ailments and diagnoses that do impact my vision. I am on blood thinners, I'm on cholesterol, I'm on, just drew a blank. But anything and everything, I have it. So I do think it's a lot to do with the blood circulation. I'm on beta blockers. I'm on those type of things. And you have to be that advocate for yourself and make sure that you make those connections with one prescription can impact another. So I make sure that when I go to the cardiologist and I see a gastrologist, all my neurology, all of this together, they all communicate with my glaucoma specialist now to discuss what medications, because I'm on the eye drop that's a beta blocker, but then they are giving me a pill as a beta blocker. Is that too much? How does that impact? So I have had some issues where they have not mixed well together, and it was some really bad issues, and it took us 2 or 3 weeks to realize the medication was something that I shouldn't be on with the eye drops, which appears it doesn't happen often, but I would be that lucky 1 in a million. So I think that's why it's really important, because you don't want those bad side effects or unintended consequences for not being vocal, and you are your best advocate. I just want to continue to say that I struggled with that early on when I had glaucoma, and I was actually a Medicaid director for Louisiana, so I advocated for 2 million lives every single day, but I could not walk in a doctor's office and advocate for myself. It took a lot out of me personally. Well, now I'm a pretty loud advocate for myself, and I think that's the biggest connection to informing all of your physicians, because you don't always know, especially with glaucoma, here's a bucket list and they start checking them. We're here, we're here, we're here. And so the other physicians may not be in tune to all of that. So it's hard to bring it up when they really don't understand. So you have to make sure that your physician group is very patient and really is willing to listen, but you have to be that advocate for yourself. And that was like really, really difficult for me to overcome.
If I can just briefly say, first of all, thank you very much for sharing that, Tara. It's really important for you to tell all of your doctors that you have glaucoma, but also as glaucoma specialists, we want to know all of your medications that you're using. And it's crucial because there's a big connection between certain medications that can affect your glaucoma depending on the type of glaucoma you have. Some people may have narrow or intermittent angle closure glaucoma. And even for people who have open angle glaucoma, if you're on a steroid, you're at much higher risk than the general public of having increased eye pressure eventually. It may not happen the first time you use steroid, but many people use steroids intermittently, chronically over the years during allergy season, for example, and it can build up in the body. So we really want to have a communication between us and you and your doctors in terms of what you're using. Thank you.
I do want to add one of the things, again, about being a self-advocate and steroids. I have terrible allergies, so you can't get in to see your physician, so you go to one of these walk-in clinics, and the first thing they want to do is pop you with a steroid shot. And if you don't advocate for yourself, they will do that. Mm-hmm. You have to let them know my glaucoma, and I can tell because in January I had the flu and ended up having a little bit of pneumonia, so I had to be on steroids. And it does impact my vision so bad. So I make sure that when I go in and tell them, you will do something else besides, if you're going to give me a steroid shot, I'm walking out. I'm not staying in. So really think about that and be that advocate for you. That when you brought up steroids, that's just one of the big ones that I face all the time. If you fall like I did, snow skiing and tear your meniscus and they want to give you steroids for healing, like, no, I can't have that. Mm-hmm. So, it's all around. That's just another key reason to make sure that everybody's on the same page.
I was going to say, also, you shouldn't have to struggle so hard to be an advocate. And so we are all different. We all have different personalities, different approaches, and this is a chronic disease. And so if the person you're working with, the doctor, just doesn't seem, if you don't feel comfortable asking the questions, then maybe you need to consider, was this the right doctor for you? The good doctor, but maybe just not the right match. With one caveat, there is a lot of advantage to having one quarterback in your on your team, in that because you have a lot of data, you have a lot of tests that have to be analyzed. So I suggest to patients, you choose whatever is most comfortable for you as a testing site, as a strategy, and then if you want to get a second or third or fourth opinion, no problem, but then kind of develop a home base. But that home base is somewhere that feels like home, that you can ask those questions. And so don't be, if it's not the right fit, this is your vision, and you're talking about a long-term relationship.
One more thing about steroids. Steroid creams and inhalers do count. We're going to be very clear about that. And so whenever patients especially come to me for the first time and they bring in a list of medications, I always double check and triple check because we forget about any creams that we're using on the face. Any sort of allergic dermatitis, any rash, a dermatologist will give you a steroid. It matters. We need to know. Also, if you have to be, like Tara, for example, on steroids for a short term for something like pneumonia, I always ask my patients, if you're started on steroids by a doctor or if you're given a steroid shot, just call us and let us know because I will have you come in and get your pressure checked, depending on how long you're on the steroids, and then we kind of watch you from there because it does make a difference.
With all this talk of allergies, let's talk about eye drop allergies. How do you all manage that?
How much time do we have?
Yeah. I'll say as a patient, when it hurts really bad and burning and red and swollen, you realize you have an allergic reaction. So it's pretty easy to go in and your physician notice that there's something wrong.
Actually, one of the small caveat, but an important fine point, there's a difference between an allergic reaction and a drug reaction. And so allergic reactions would mean, that it stimulates, you can be allergic to bees, you can be allergic to certain foods, and that can actually kill you. Your neck. So that's we use the term kind of loosely, but what it really is a drug reaction. And so, for example, we were talking about brimonidine. It actually makes your blood vessels a little smaller on the surface, and then with time, you just want to put more and more in. But then actually when you stop it, your eyes are even redder until your blood vessels get back to their normal state. So it's not really an allergic reaction, it's really a drug reaction. And then it's a matter of experimentation. You got to figure out if you're on 2 or 3 or 4 different medications, which is it, or is it the preservative? You know, and then you do investigative. We certainly have our culprits that we think are more commonly the cause, but that's part of the, you know, the fun of trying to be detectives and figure out what it is that's actually the source of your problems. So
we have just about 5 minutes left, and what's next is lunch, and we don't want to keep everybody from lunch. So we got a really excellent question that I would love to hear all of you weigh in on, which is, why isn't there one treatment plan for everybody? Big question. Is our last question. Why is each person different? Why does it take time to find the right combination of medication and surgery?
I think, as Dr. Pickering and Dr. Iwach beautifully presented, life expectancy, when patients are diagnosed, at what stage in their glaucoma they're diagnosed, what type of glaucoma they have. Unfortunately, sometimes even what type of insurance will cover a certain medication or a certain surgery, whether they're being treated in private practice or in a university setting, it does make a difference. And, you know, we know that, just as an example, we were talking about drug reactions. I've had patients who've been on bromonidine for 50 years and have never had a problem with it. I would not be able to tell you why. Then I know other patients who'll try it, and within the first month, they come in and they want to claw their eyes out of their head. And so, unfortunately, many of the treatments are unpredictable, and glaucoma is kind of just a bucket diagnosis of many subtypes of glaucoma, and depending on the stage, your age, your medical issues, you know, and other kind of chronic issues that are occurring. And of course, the big question mark, which is we have no idea how you're going to respond to a specific treatment. So some of this is trial and error, and a lot of this is, that's why it's so important for you to feel comfortable with your clinician, to be able to ask any questions that you can ask. And, you know, patients will come to me for the first time with so many questions. They're stressed. Am I going to be blind? I don't know. And I tell them, look, I can't predict the future. I can promise you that I'll be as honest with you as I can, and I'll be as thorough as I can. And, you know, the disease will tell us about itself over time. And I found that patients in general over time tend to become a little bit less overwhelmed as they become more comfortable with you and they can see that you care as a clinician and you want to find kind of the best treatment for them.
That was beautifully put, and I don't have all that much to add, you know, just to harp on that. Everyone is different, everyone's eyes are different, everyone's optic nerve and the eye pressure that optic nerve can tolerate is different, and so it's just impossible to have a really staged approach that's the same for everyone when treating the disease.
And I agree with everything that's been said. I would also give you permission to live your best life. Trust us. Ask questions, verify, but most people who have glaucoma will maintain useful vision for the rest of their lives. So we do the tests, we look at it carefully. You know, do you have to, everyone have to check their pressure at 2 in the morning? Absolutely not. You know, we have the things we do in the office working with you, we want to keep you seeing but maintain the highest quality of life for you at the same time. And so, again, it is, yeah, things can happen. You get hit by a truck. I mean, we don't have a perfect crystal ball, but we can at least give you a sense, especially after we've seen you a few times. We look at the trends and say, you know what? I think you look very stable, but we're going to keep looking carefully. In the meantime, you know, do that drop or do what we've asked you to do, and odds are you're going to be okay. And one last thing, when you get together with the family and you don't know what to say and you have glaucoma, give the gift of sight, make sure they get their eyes checked.
Thank you. Now I know what to talk about with my family, but real quick, I want to echo Dr. Barsegian, you're exactly right. Every body is different. I just want to emphasize that our bodies are also different at different ages. I've had the true honor of taking care of patients, some of whom I've taken care of for decades, and their bodies have changed, and their glaucoma has changed. And this is why you need to maintain that relationship and keep with the monitoring.
Any last thoughts from you two? Yeah? Okay. Well, let's thank our amazing panel. That was wonderful.